Hello and welcome back. So today we'll be discussing an approach to superficial dermal disorders, and this will be part 2.2 of the general heading of an approach to rash. So these will be the topics that I'll cover in today's discussion. First, we'll review some generalizable concepts pertaining to superficial dermal pathologies. Then we'll talk about one very specific pathology, that is urticaria. We'll understand the three pathways that lead to urticarial lesions, deduce the clinical differentiation of these three disorders, understand why something called erythema marginatum has such a characteristic presentation. Then we'll also talk about angioedema because being a practicing clinical immunology and rheumatology consultant, I get a lot of patients with angioedema, and this is something that happens with medicine, internal medicine people as well. So we need to understand exactly what is the difference between angioedema and urticaria, and therefore how would you go about investigating or evaluating a patient with these disorders. Uh, so first we'll understand the differences, then we'll understand angioedema at a deeper mechanistic level. Then we'll understand that there are actually two different types of angioedema, uh, slightly reductively referred to as histaminergic and non-histaminergic angioedema. Then we'll talk about the types of non-histaminergic angioedema, which is actually the main thing that concerns us in clinical immunology and rheumatology as well as internal medicine. And then uh, there'll be a bonus section on the genetic basis of non-histaminergic angioedema with normal C1 esterase inhibitor activity. So that is something that you need not go into very great detail with, but obviously, in this channel, I don't like to skimp on detail. I like to present the entire thing in its whole. So we'll discuss the entire thing completely. Okay. So now, starting with the first thing, the generalizable concepts that I was talking about pertaining to superficial dermal disorders. Okay, so how well would these lesions be demarcated? So they're obviously superficial dermal disorders. There is only epidermis and the dermal-epidermal junction right above it. So these are likely to be very well demarcated. But since the superficial and deep dermis are in essentially the same compartment, you're likely to find that there are parts of the lesion that may be extending deeper into the dermis. So such lesions will show areas that are not as well demarcated, of slightly decreased demarcation. Okay, so this is the first thing that we can deduce from what we've understood already. Now, the second thing that we can deduce is what would be the lesion color. So again, this would depend on the skin color of the patient in general. Okay, and it will depend on how deep the lesion is. So since it is superficial dermis, the more superficial the lesion is, the less Rayleigh scattering will occur. So the more red it will be. Okay, and the deeper the lesion is, the more the Rayleigh scattering because it has to pass through more skin and while coming out. So the more violaceous it will become as um, the red components of the light that is getting reflected off the lesion get filtered out. Okay, so this is clear. Then, what would there be any associated epidermal changes? Now, yes, that depends on the lesion, I guess. Okay, and those changes could be of two types. They could be psoriasiform changes, or they could be your uh, your as I've discussed previously, your changes synonymous with eczema or atopic dermatitis, like changes or spongiortic dermatosis. Okay, so that those entities we've already discussed in our initial discussions in this series. So the same principles apply as they did there. Now coming to urticarial disorders. So before we discuss urticarial disorders, we need to understand what is urticaria. Okay, so urticaria essentially just means there is dermal extracellular fluid accumulation. Okay, so because of that, what ends up happening is that if this much area of the dermis is Okay, I'll use a white thing. If this much area is, of the dermis has become, has become edematous, usually the dermis has become edematous because the capillaries have dilated. So in this entire area, the lesion should be relatively red in color. Okay, but where dermal edema has occurred, in those areas, the blood vessels have an external pressure compressing on them, so those blood vessels collapse. So instead, what you get is this: you get a lesion which has got central pallor. Okay, and central area is raised, maybe slightly violaceous. Okay, and the periphery of the lesion is showing a erythematous surrounding skin. So this is actually what we call urticaria or an urticarial lesion. Now, actually, this is what we would call an urticarial lesion, and but urticaria is different from urticarial lesion. Then we'll see how that is. So obviously, the essential tenet of urticarial lesions is there should be a dermal edema, and for that we need to understand the functioning of dermal capillaries. And actually, this is these concepts obviously can be extrapolated to all other capillaries except for a few, such as the pulmonary capillaries. So, any capillary has an arterial end and it has a venous end. Okay. Now, at the arterial end, the hydrostatic pressure is a little higher. So, as a result, fluid comes out into the extracellular space. At the venous end, the because the fluid has got come out, there is a gradual increase in the oncotic pressure. And that oncotic pressure essentially results in a suction into the capillary at the venous end. So there is an equal amount of fluid going out at the arterial end and coming in at the venous end. Now, this what I have drawn here, this is a neutrophil that is there within the dermal vessel. And this neutrophil is moving in the blood within the vessel. And towards the venular end or the venous end of the capillary, we have a special group of endothelial cells called the high endothelial cells. Okay, and this is something that I discussed in my discussion on the use of lymph node histology for evaluation of generalized lymphadenopathy. But essentially, these are the endothelial cells that interact with circulating inflammatory cells and allow those cells to enter into the extracellular matrix surrounding the blood vessel. So this neutrophil interacts with this high endothelial vessel. Then tra- you know, uh, it moves across the endothelium, okay, through a process called transmigration and eventually reaches the extracellular space. So this is how a normal dermal capillary functions. Now, there in urticarial lesions, or rather the three types of urticarial lesions, this there are subtle changes that happen, which though there may seem like a lot of nuance, uh, informs us regarding the clinical possible cause of the particular lesion. So, in the first diagram here, you can see that this here around is a mast cell. How do I know it is a mast cell? Because I have put basophilic granules in its cytoplasm. It's a relatively large histiocytic cell otherwise. Okay. So what happens is that the mast cell or a basophil releases histamine and bradykinin. Okay. So that histamine that is released that goes and activates histamine receptors, specifically the H1 receptor, and that causes the endothelial cells are in the capillary to contract, and that results in an increased permeability of the capillary to fluid, and there is fluid leakage into the extracellular matrix. This happens both at the capillary arterial end and at the venous end. So this is unusual. This is an abnormally functioning capillary bed. Okay, so this causes edema, but or the dermis. But importantly, this edema is transient because as soon as the histamine has been metabolized, that edema will resolve, and once the edema resolves, it will be a transient process. Similarly, it will be associated with itching because again the mediators that the mast cell is releasing also activate neurons that are located in the dermis surrounding this blood vessel. So this is what we call true urticaria. It is a transient dermal edema. So it looks just like urticaria, the urticarial rash that I discussed earlier, but it is transient and it is itchy. Okay. There is no reason for it to degenerate into an ulcer or to have any pain. Hmm. Now, the second thing that might happen is you might have an obstruction of this dermal capillary at the venular end. Now, this happens because of intravascular thrombosis. Now, this kind of thrombosis typically occurs because of intravascular netosis. Netosis is extrusion of nuclear material from mostly neutrophils, but to some extent also other macrophages and histiocytes. Um, that results in a local release of nucleic acids and the bound histones into the extracellular space around this neutrophil. And when neutrophils undergo netosis, that process can be of two types. It can be with the neutrophil remaining alive, okay, or it could be with the neutrophil dying in the process. So either way, we'll discuss that at a later date. So this diagram here, this is what is happening. That is, then there is netosis that is happening. Okay, so when netosis happens, that provides a substrate for the formation of a thrombus, and therefore thrombus formation starts. And when there is thrombus formation at the venular end of a capillary, obviously there is back pressure towards there is backup of blood in the capillary. That increases the hydrostatic pressure within the capillary. And that increased hydrostatic pressure again causes a really impaired reabsorption of dermal fluid at the venular end, or rather even increased capillary, loss of fluid into the dermis at the venular end. Okay. So again, the same thing is happening. However, if you think about it critically, this is actually subtly different from what we saw with true urticaria. How is it different? First of all, the dermal edema is due to this thrombus. So it's not something that's just going to resolve on its own. It will take time. Okay. Second thing is, see, this is happening at the venular end, but if the disease process increases a little bit more, it can happen a little bit more proximally also. Okay, so the same process could affect, slightly larger proximal vessels, and that can cause dermal and epidermal infarction. So that infarction would result in pain. So this type of dermal edema is one, more persistent. Second, it is associated with pain, and third, it is can be associated with actual dermal infarction or epidermal infarction and secondary degeneration of the lesion. Now, the third thing that might happen is you could have again capillary obstruction, but at this point of time, it is not neutrophil netosis that is causing this. It is neutrophil activation at the venous end. Okay. Now, why would the neutrophil get activated at the venous end? Bec- This is because in a group of disorders that we have, the endothelial cell, the high endothelial vessel cell, has got some kind of inflammasome activation. So inflammasomes are cytoplasmic, protein complexes that detect certain signal pathogenous or molecular pattern or damages or molecular pattern, and then produce interleukin 1. So that ends up producing interleukin 1 beta from the endothelial cell. That acts on surrounding neutrophils and causes them to our um, interact with our endothelial cell and come into the extracellular space surrounding this endothelial cell. Now, this neutrophil now starts to damage the endothelial cell. Okay, neutrophil mediated damage occurs to the endothelial cell, and that then secondarily results in a thrombus. Okay, so again, this process is similar because now there's going to be back pressure into the capillary bed, and therefore there is going to be increased fluid release. Okay, so the increased capillary hydrostatic pressure will be there, and there will be fluid release from the capillary because of that. Okay, and there will be dermal edema. It's very similar to what we just saw with urticaria vasculatus. However, the important thing is if you take a biopsy of this lesion, you will find neutrophils all around the capillary bed trying to damage the endothelium. So there will be neutrophils in the dermis, and this is what we call, you know, neutrophilic dermatosis. Okay, so this is a neutrophilic dermatosis with urticaria. So I call this neutrophilic urticaria. Okay, so these three types of urticarial lesions are subtly different. Okay, the first one has always transient dermal edema, which is associated with significant itching but not associated with pain. And the other two are persistent dermal edema associated with significant pain with or without dermal infarction or dermal degeneration in case of neutrophilic dermatosis. However, in case of neutrophilic dermatosis, when you take a biopsy, you find a very dense neutrophilic infiltrate surrounding the blood vessel. Actually, at the venular end, but obviously in a biopsy, you cannot tell that it is a venular end. But you find a perivascular dense neutrophilic infiltrate. So, now the true urticarial lesions can be due to mast cell degranulation secondary to type 1 hypersensitivity, that is local Th2 polarization resulting in class switching of local B cells from IgG to IgE, and then IgE, goes and binds to the surface of these mast cells and causes them to degranulate. Okay, so that is your atopic disorders. Then something called Gleach syndrome. Okay, which again is an antibody directly targeting the Fc epsilon receptor, that is the receptor that binds to these IgE and the normal circulation, causing again macrophage degranulation. Then angioedema, which we'll get to just now, just in a bit. This also includes neoplastic disorders when it's the number of neutral mast cells and the type. There's increased number of mast cells and they are dysplastic or they function abnormally. Now, with urticarial vasculitis, often what we have is we have an anti-C1q antibody which is present in the vasculitis. Now, anti-C1q antibodies can, essentially result in abnormal complement activation, resulting in this kind of excessive neutrophil netosis. So this includes actually cryoglobulinemic vasculitis, and it can include ANCA-associated vasculitis, but actually any type of small vessel vasculitis can technically have urticarial vasculitis. Okay, so next we have a neutrophilic urticaria, and the prototypical disorder associated with neutrophilic urticaria in adults is something called Schnitzler syndrome. Now, in Schnitzler syndrome, very briefly, you have a patient who has a Waldenström macroglobulinemia, which is a plasma cell neoplasm, and that produces IgM immunoglobulin. And that IgM immunoglobulin is specifically targeted, happens to develop an affinity for a particular type of potassium channel located on endothelial cells. That is called your DPP, that is dipeptidyl peptidase 10 potassium channel, and that results in that potassium channel not functioning properly, which is a signal for for secondary activation of the inflammasome NLRP3. Okay, now if this doesn't make that much sense to you, I'm going to be discussing this in detail as a separate topic. Now, either way, that is what happens in Schnitzer syndrome. So, because of that, there is increased interleukin 1 beta production, and that increased interleukin 1 beta production is what we've just seen is the cause of neutrophilic urticaria. Now, this can also, if you have a genetic problem in which these inflammasomes are overactive. So that includes a group of diseases known as the cryopyrinopathies. This includes FCAS, that is familial cold autoinflammatory syndrome, Muckle-Wells syndrome, and Moment, which all fall under the general heading of cryopyrinopathies. Then let's move on to the actual histology. So what do we see here? We see that there is actually a lot of dermal edema. How do I know there is dermal edema? There is a separation of collagen fibers. The collagen fibers in the epidermis are separated from one another. There are there is definite dilatation of dermal vessels. These vessels here are actually visible. Usually dermal vessels are not that visible. Okay. And within the blood vessels as well as outside of the blood vessels, some extent, there are some infiltrating cells. Now, it's not very clear what cells they are, but some of the cells are very orange, so they're likely eosinophils. However, the issue is that essentially any of the three pathologies that I've just described could recapitulate this kind of a histological appearance almost exactly. Okay, probably with urticaria, you would get more dense neutrophilic infiltrate, but then that's again a probably. Okay, patients get gotten steroids, you might not get that. And similarly, with the atopic disorders, you might expect a more of a eosinophilic infiltrate, but again, you can't be so sure about that. So these are the issues that arise, and therefore biopsy is not the best way to differentiate these disorders. So I don't know how many times I've discussed this with people, but again, I reiterate, histopath is only one aspect of the clinical assessment of the patient. It is not the final diagnosis. Okay. Anyway, so let's just differentiate these three disorders formally. So we have true urticaria. So that is, it is self-limited in 6 to 12 hours. Any longer would be highly unusual because obviously this is histamine mediated. Histamine being a histid is being a something that has been synthesized from an amino acid histidine is actually pretty easy to degrade and it degrades fast. It is associated with significant itching, okay, but no pain. And possible etiologies, as I've just discussed, are atopic disorders, that is IgE mediated, Leach syndrome, angioedema, particularly hereditary angioedema, and essentially any neoplastic lesion with increased mast cells. Then urticaria vasculitis and neutrophilic vasculitis both have attacks that are prolonged and typically last for more than 72 hours. Okay, any sort of would be unusual. They are painful and they can be secondary tissue necrosis because of infarction in case of urticarial vasculitis and because of neutrophil mediated damage in case of neutrophilic urticaria. Then necrosis is that happens is always secondary to infarction and thus may form purpuric lesions that can degenerate into deep lesions. Okay, deep ulcers, and obviously the neutrophilic urticaria is a neutrophilic dermatosis. You find dense neutrophil infiltrate in the dermis. Etiologically speaking, urticarial vasculitis can be secondary to anti-CEC1Q antibodies, as you will commonly see in patients with SLE, okay, or cryo, and you can have ANCA-associated vasculitis. Similarly, neutrophilic dermatitis can be part of Schnitzler syndrome in adults, and it could be part of an inherited or monogenic autoinflammatory disorders with, cryopyrinopathies, that is your FCAS, mucous and vomit. Now, coming to erythema marginatum. So, what is erythema marginatum? This is erythema marginatum. Okay, so just without knowing that it is erythema marginatum, what can I say? That there is central pallor, there is surrounding erythema. Okay, and these lesions seem to be forming these weird shapes. Okay, weird figures. So that is why we call it a figure eight lesion. Okay. Uh, Erythema marginatum obviously characteristically occurs in your acute rheumatic fever, but it also occurs in hereditary angioedema. And that neatly brings us to how urticaria relates to angioedema. Okay. So now, in the next part of this discussion, I'm going to be talking about angioedema, and I'm going to be going to try to explain to you why the presence of urticaria, angioedema in urticaria, doesn't necessarily negate the evaluation of urticaria as I've just discussed. Although, however, if you have isolated angioedema and no urticaria, the evaluation is slightly different. So that is something that we're going to discuss. Okay. So now what is the difference between urticaria and angioedema? So we'll just compare them head to head. First of all, in urticaria, the involvement is, as we've just discussed, as you would expect from the name of this lecture, it is superficial dermis. Okay. Whereas in angioedema, there is deep involvement, deeper dermis involvement, and subcutaneous tissue involvement. Urticaria and angioedema can essentially involve any part of the body, but by virtue of the urticaria involving the superficial dermis, the lesions are well demarcated. Whereas in case of angioedema, obviously the lesions will not be well demarcated. That is very natural and to be expected. Uh, Again, the morphology of urticarial lesion is that there is central blanching with a surrounding erythematous serpiginous border. Okay. And lesions may coalesce as we just saw for erythema marginatum, forming a figure eight lesion. Angioedema is just swelling with minimal surrounding erythema. Symptomatically, urticaria is often pruritic, although urticarial vasculitis and neutrophilic urticaria can be painful. Whereas angioedema is usually actually asymptomatic, but when it is symptomatic, it is usually painful. So that is something that is to be understood. Now, after that, your signs, urticaria is associated with a very interesting finding that is called dermographism. So dermographism essentially means that if you draw on the skin of the patient, you end up getting the path that you follow. The lesions will follow that exact same path. Okay, so that is called dermographism. There are no specific signs that are specific to angioedema. So let's just understand what is happening in angioedema. There is mast cell degranulation, much like we saw with urticaria. There is a release of bradykinin. Bradykinin is converted into desarginine bradykinin, that is a metabolized version of bradykinin, or it acts directly through two receptors. Directly, bradykinin acts to bradykinin 1 receptors, and once it is converted to desarginine bradykinin, it essentially acts via the bradykinin 2 receptor. This causes phosphorylation of proteins called cadherins, which form part of the zona adherens, that is the the tight junctions between epithelial cells, rather the endothelial cells, resulting in these endothelial cells becoming essentially separated from another, and as a result, there is leakage of fluid into the tissue surrounding those vessels. So that's what's happening with angioedema. And this arginine bradykinin production is catabolized by an enzyme called carboxypeptidase. There are two of the N and M. Okay. Now, so angioedema essentially occurs due to bradykinin production and subsequent activation. Okay. And this may be due to mast cell degranulation, but there is another thing that it could also be there due to increased downstream activation. Okay. Now, this downstream activation is caused by a pathway called the contact activation pathway, and we'll just get to the details of that subsequently. Histamine, okay, so not histamine. I mean, mast cell degranulation doesn't release bradykinin; it also releases histamine. So this is not histamine degranulation. This is mast cell degranulation. So mast cell degranulation releases not just bradykinin; it also releases histamine. Okay, among other things. Now, therefore, we have release of histamine from these degranulating mast cells. That histamine causes activation of histamine receptors, resulting in local vasodilation, as we just saw for urticaria. And this actually happens predominantly in the skin and mucosal line surfaces, unlike angioedema, which happens in deeper surfaces. Now, the reason for this is something that is rather interesting. Uh, this is because mast cell degranulation is most commonly caused by Th2 polarization in near epithelial surfaces, and we've discussed in discussion on atopic dermatitis that Th2 polarization only happens near intact epithelial surfaces that are leaky to proteins. Okay, that results in these Th2 cells causing IgE class switching in B cells and production of local IgE. This IgE cross links the receptor for the IgE-Fc portion on mast cells, resulting in mast cell degranulation. So obviously, so this kind of Th2 polarization and IgE production can only happen right next to mucosal barriers. That is why it happens on the skin, it happens in other mucosal areas. Okay, so just remember what we discussed in atopic dermatitis. Now, this IgE cross-links the Fce receptor epsilon on mast cells and then signals them to degranulate. But the contact activation pathway downstream of this is not really activated. So there is no unnecessary activation or contact activation. So you need not actually get angioedema. Okay, I hope that that is relevant. That is clear. So downstream activation of bradykinin vis-a-vis histamine would not be just so evident. So basically, there are two mechanisms to development of angioedema. One is you have it occurring with urticaria. That is, there is skin or mucosal IgE production due to increased Th2 polarization. That IgE coats the mast cells, causes them to get degranulated. Uh, this could also happen due to mast cell induced degranulation by alternate mechanisms. That releases histamine and bradykinin, but this bradykinin is not getting significantly activated because there is minimal activation of downstream activation pathways like the contact activation pathway. The other thing is that there is just increased bradykinin activation. There is no significant increase in mast cell degranulation. And this is happening because the downstream activation of the bradykinin has increased. This happens to three mechanisms. It happens either due to overactivation of the contact activation pathway. It can happen due to classical complement pathway overactivation, and it can happen due to inflammation resulting in the production of a particular damages molecular pattern that is called HSP19, and we'll just be getting to the details of this. But broadly, therefore, angioedema can be divided into two categories. What is called histaminergic, that means basically angioedema that occurs concurrently with urticaria, and non-histaminergic, that is angioedema that occurs in isolation. Histaminergic is due to mast cell degranulation. This mast cell degranulation need not be due to IgE production only at mucosal surfaces. It could be due to alternate mechanisms, but always it is near a mucosal surface or skin. So therefore, it is associated with urticaria. Now, clinically, what are the other clinical things that help us differentiate histaminergic versus from non-histaminergic angioedema? So, like in any other symptom, there is onset, progression, duration of symptom, site, radiation, would not really radiation is not applicable since it's not pain, severity and character. So, see, histamine is a preformed amino acid derivative, synthesized from histidine. Histamine is then metabolized rapidly. Okay, so naturally, the onset of histaminergic angioedema will be sudden over a few minutes. Okay, uh, whereas bradykinin is not produced so acutely, so is not you know not produced in a preformed fashion. It has to be activated. So angioedema, that is non-histaminergic, occurs over some period of time, usually over a few hours. Then bradykinin, being a peptide, is also metabolized relatively slowly. So therefore, histaminergic angioedema resolves in very rapidly, that is within 24 hours. Whereas your non-histaminergic angioedema resolves, it takes a longer time to resolve, usually 24 to 72 hours. um, the site, as I've just discussed, is on areas that are right next to mucosa or skin, and these are exposed areas of skin, particularly if you have that kind of, urticaria associated angioedema. Whereas non-histaminergic angioedema can occur anywhere, essentially any deep tissue. However, importantly, in hereditary angioedema, the distribution is actually very characteristic, and we'll just be getting into that. It depends on the genetic cause. Now, severity of angioedema actually doesn't depend on whether it is histaminergic or non-histaminergic, although, anecdotally, non-histaminergic is more severe. Um, Severe as in the amount of, edema that occurs. Um, Character-wise, as I've just discussed, in histaminergic angioedema, urticaria is almost always present. Okay, whereas most importantly, non-histaminergic angioedema is only angioedema. It is nothing else. Okay. Um, Now, histaminergic angioedema is aggravating depending on the cause of the mast cell degranulation. So, that mast cell degranulation could be caused by IgE cross-linking, or it could be, essentially caused by some kind of, mechanical exposure that's causing mast cell degranulation, or sun exposure that is causing mast cell degranulation, like somewhat is called solar urticaria. So, etc. Now, non-histaminergic angioedema, again, the aggravating features depends on the cause, and in hereditary angioedema, particularly, stress is one major reason for your aggravation. Now, histaminergic angioedema, the lesions, the problems are happening because of mast cell degranulation. Okay, so often, if you prevent that by giving corticosteroids or epinephrine, that resolves the symptoms. And if it's just urticaria or just itching that are the main symptoms, even antihistamines do the job. Okay. However, nothing really works on non-histaminergic angioedema. So resolution with exposure to corticosteroids or epinephrine would be extremely odd, would not favor non-histaminergic. Now, in case of associated features, histaminergic angioedema can be associated with bronchospasm, because you must remember that that is also an epithelial surface. Okay. Histaminergic angioedema doesn't cause bronchospasm. Now, some of you will be thinking, that's not right. You get respiratory distress. Now, when you get respiratory distress in non-histaminergic angioedema, it is due to laryngeal edema. Strictly speaking, histaminergic angioedema is actually causing submucosal edema, superficial, in the glottis, the glottic folds, whereas non-histaminergic is causing very deep edema. Okay, but obviously clinically both of them are causing obstruction to airflow, and that obstruction to airflow naturally is resulting in your patient having a stridor or laryngeal edema. Okay, and that is you can. There are subtle differences when you look at it through on your when you directly visualize it through laryngoscopy, but that's not that helpful. So, and it is a little difficult to do in such patients. Clinically, it is not a feasible thing to do. Now, coming to abdominal pain, see, abdominal pain is not likely to occur in histaminergic angioedema, essentially because even though the GI tract is a epithelial line surface, it is a immune. The threshold for immune activation in the GI tract is significantly higher, as I've discussed in a discussion on IBD or inflammatory bowel disease. So that area is not normally affected in histaminergic angioedema. And abdominal pain due to, essentially, you know, your submucosal edema and, secondary compression of blood vessels there and distortion of the viscera can be present in cases of non-histaminergic angioedema. Now, hypotension occurs in cases of histaminergic angioedema because it is histamine that causes vasodilation. Uh, Antihistaminergic and non-histaminergic angioedema usually does not have hypertension. So essentially, what I'm trying to get at is if you have a patient who has bronchospasm and has hypotension, okay, that means it is mast cell degranulation, and the patient when doesn't have abdominal pain, then the patient has histaminergic angioedema. If the patient doesn't have bronchospasm or hypotension but has developed episodes of abdominal pain in history, then that is non-histaminergic angioedema. Laryngeal edema can essentially occur in both and does not differentiate the two. Now, going into the details of the different types of non-histaminergic angioedema, we have hereditary angioedema due to the deficiency of something called C1-INH or C1 inhibitor. Okay. C1 inhibitor obviously is an inhibitor of the classical complement pathway, and additionally, it also inhibits, the proteins that activate bradykinin. Okay, so naturally, if you have a deficiency of C1 inhibitor, you have excessive activation of the classical complement pathway and therefore usage up of C3 and C4 by the complement pathway. And you have excessive bradykinin activation resulting in angioedema episodes. You can have hereditary angioedema without C1 esterase inhibitor deficiency, and we'll get to that just subsequently. You can have idiopathic, what is called idiopathic non-histaminergic angioedema, which basically means it is a non-histaminic angioedema, but on genetic testing you don't find any deficiency in either C1-INH or you don't have any mutations in the other genes that have been applicated in hereditary angioedema without C1-INH deficiency. Then we have acquired angioedema with C1-INH deficiency. So here, a acquired disorder, usually an autoimmune disease, causes an antibody to form that combines to and inhibit C1-INH, resulting in a type of histaminergic angioedema. So, pathophysiologically speaking, hereditary angioedema due to C7-INH deficiency, there is a deficiency of C7-INH function. So, in type 1, there is actually a reduction in the production of C1-INH. In type 2, we have a functional defect in its function. Okay, so it is not able to inhibit the classical complement pathway and activation of bradykinin adequately. Now, hereditary angioedema without C1-INH is most commonly due to mutations in the factor 12A, which is the initiating factor in the contact pathway. But there are others, and this will just come to. Okay. Now, idiopathic non-histaminergic angioedema, essentially, we don't know the cause for. Okay, there is activation of this bradykinin, but why it is happening, we really don't know. It could be multifactorial. Um, then we have acquired angioedema with C1-INH deficiency. So here we have an antibody, as I just alluded to, that is targeting your C1-INH and essentially through a type 2 hypersensitivity mechanism is causing it to lose function. Okay, this can happen with immunological disorders. It can also happen in any non-Hodgkin lymphoma where an antibody production is happening. Okay, for example, in CL, chronic lymphocytic leukemia. Now, inheritance of hereditary angioedema due to C1-INH deficiency as well as without C1-INH deficiency are both autosomal dominant. Okay, and this is a previous NEET SS or INISS question. So this is something that is important to know. However, due to C1-INH deficiency shows complete penetrance. So there will be similarly severe episodes in all in at least 3 generations of the same family. Whereas when it is without C1-INH deficiency, it is with incomplete penetrance. So even though more than equal to 3 generations of the same family are affected, and males and females are affected, the severity of affliction is different. Obviously, idiopathic non-histaminergic angioedema is not a genetic disorder, and acquired angioedema with C1-INH deficiency is not an genetic disorder, so that doesn't apply. Now, age of onset of C1-INH deficiency related hereditary and non-histaminergic angioedema is childhood or very young adulthood. non-C1INH deficiency usually starts after childhood when the patient is an adolescent. Idiopathic non-histaminergic angioedema peaks between 30 to 40 years of age, and acquired angioedema with C1INH deficiency usually occurs in patients who are a little bit older, that is more than 40 years of age. Although in autoimmune disorders it can occur a little earlier. So these are not hard and fast rules. Basically, the earlier it is, the more likely it is CNINH deficiency, hereditary angioedema, and the later it is, the more likely it is to be acquired angioedema with CNINH deficiency. Now, obviously, both hereditary and acquired angioedema with defective CNINH function in serum or ECF have excess activation of the classical complement pathway, and therefore they can have C4 or with or without C3 hypocomplementemia. Okay, but see, this classical complement pathway is not just randomly activated. Okay, all the time. It has to be activated by very specific initiating mechanisms. So it may not always be active. Therefore, this kind of consumption may not always occur. So you can have normal C3 C4 levels, but obviously, if you have reduced C3 C4 levels, that is highly suggestive that the patient has got a C1INH function deficiency. Obviously, then we also measure the C1INH levels in blood as well. Okay. Now, obviously, hereditary angioedema without C1INH deficiency and idiopathic non-histaminergic angioedema would not have this. Okay. Now, coming to the triggers. So, hereditary angioedema due to C1INH deficiency and without CNH deficiency is often triggered by stress, particularly trauma. Okay. It can also be triggered by infection, and anecdotally also is triggered by yeah, uh, fatigue. Okay. Now, hereditary angioedema without C1INH deficiency, as I discussed, is most commonly caused by a factor 12 deficiency. So, factor 12 deficiency can be induced by estrogen exposure. So, that would be OCP pill usage, or, in a patient who's pregnant. So, if it is getting precipitated by pregnancy, then it strongly points towards a factor 12 deficiency. There are no specific, precipitants for idiopathic non-histaminergic angioedema. Acquired also does not have precipitants. Attack duration, the distribution in case of hereditary angioedema due to C1INH deficiency, it is by almost exclusively the extremities and the abdomen, and there is sparing of the face. Okay. Whereas your without C1INH deficiency, all of them essentially have contact pathway activation. We'll just get to that. However, the attack duration is longer, and that they usually affect non C1INH deficiency associated hereditary angioedema. All other types of non histaminergic angioedema typically affect the face more than they affect the abdomen or extremity. And this is a very clinically relevant thing, because recently, about a month back, I had a patient who had bilateral ocular, lid angioedema since around 30, around mid 20s, and or early 20s rather. So just that fact made it more likely that it is hereditary angioedema without C1INH deficiency, or it is idiopathic histaminergic angioedema with the small possibility of an acquired C1INH deficiency. However, C1INH levels were normal and C3 C4 levels were normal. So then I narrowed it down to hereditary angioedema without C1INH deficiency or idiopathic non-histaminergic angioedema. Now, the patient did not have a history of, worsening during pregnancy. So, factor 12 deficiency was less likely. So, I was left with the other genetic mutations. Uh, I did not pursue that testing because further testing, would not have changed the treatment protocol. So, however, you know, uh, so therefore, genetic testing must only be done in case you wish to, counsel the patient regarding inheritability in the next generation, but otherwise it's unnecessary. So the patient is now again pregnantly pregnant, and I'll consider genetic testing based on you know whether or not the patient wants to uh, wants to have that information available to her. Now, importantly, we'll come to it, but one of the non-C1INH deficiency hereditary angioedema genes is plasminogen, and that is has been characteristically associated with tongue swelling and that is something that you can pick up clinically. So with factor 12 deficiency, you have with precipitation with estrogen, and with plasminogen deficiency, you have tongue swelling. Okay. So now in this discussion, as of now, I have discussed some generalizable concepts pertaining to superficial dermal pathologies. I have discussed about urticaria. Specifically, I have discussed the what are the three types of pathways that result to in urticarial lesions. We've deduced how to clinically differentiate these disorders. We'll be discussing, the details of. We've already discussed the details of atopic dermatitis previously. We'll be discussing Gleach syndrome, Schnitzler syndrome, urticarial vasculitis in subsequent videos in this series. Uh, Schnitzler will be discussing under an approach to generalized lymphadenopathy because it occurs in Waldenstone macroglobulinemia. Um, then we've understood why erythema marginatum has such a characteristic presentation. We have understood why the presence of urticaria in a patient with angioedema completely changes the way we look at angioedema. So we have also then deduced what is the difference between urticaria and angioedema, understood the what angioedema is mechanistically. Okay, we've understood there are two types of angioedema: histaminergic, that is due to mast cell degranulation, and non-histaminergic, that is due to distal bradykinin overactive activation of bradykinin by the contact pathway till now, and then two other pathways as we've discussed till now. Then we found that there are many different types of non-histaminergic angioedema, four different types, and we have seen how to differentiate them. Now we're going to try to understand the genetic basis of non-histaminergic angioedema with normal C1 esterase inhibitor activity, and this is can be avoided if you are not interested in understanding this in the genetics in great detail, because it's going to be a little complicated. However, if you are interested in the details of things and you want to get to the final diagnosis, please consider watching the rest of the video. So, let's talk about hereditary angioedema and gain some mechanistic insight. So, like I said, there are two pathways that can result in downstream activation of bradykinin. Okay, that is the complement pathway, and then we have the contact activation pathway. Okay, so what exactly is causing this excessive activation of bradykinin downstream? Now, bradykinin is activated by a protein complex consisting of HMWK, that is high molecular weight kininogen, bound to a protein called procalcrin, which is then converted to a protein called calcrin. Its activated version, that is calcrin. Okay. Now, this process, this process can be activated by multiple mechanisms. Okay, so precalcrin is converted to calcrin by the classical complement pathway, as I've just described. So the classical complement pathway produces the classical C3 convertase, and the classical C3 convertase, and we'll be discussing the classical complement in in my upcoming series on fundamental immune mechanisms. Uh, Essentially, it produces a protein complex called the classical C3 convertase complex, and that converts pre-calcrin to calcrin, resulting in activation of that complex. Now there is another complement system called the mannose binding lectin pathway, which activates two proteins known as MASP1 and 2, which are homologous to your C1q of the classical complement pathway, and we'll get to it there. Okay, so as you can see, both the classical complement pathway as well as the mannose binding lectin pathway can result in activation of precalcrin to calcrin. Okay. Now, inflammation and resultant release of damaged associated molecular patterns like HSP19 can also activate the same complex in the same way. Hmm. Now, factor 12, which I told you is activated, is a contact activation part of the contact activation pathway, can be activated when factor 12 comes in contact with dysregulated endothelia. Okay. Now, this factor 12 also activates high molecular weight kininogen bound precalcrin and converts it into calcrin. Okay, so all of these three pathways, as you can see, downstream activate bradykinin. And we've seen, so this is becomes quite clear that if you have a gain of function mutation in factor 12, that would result in excessive activation of calcrin. Okay, and then downstream activation of bradykinin. That is pretty obvious. Now, uh, high molecular weight kininogen bound to kallikrein not only activates bradykinin, it also feedback activates factor 12A, and there that is why factor 12A mutations result in this very odd presentation. I tried to bring to your notice that the patients get the disease that is precipitated by estrogen exposure. So during pregnancy, OCP usage, etc. Now, factor 12, as is more commonly understood, is actually part of the intrinsic coagulation cascade, right? So it activates factor 11, converting into factor 8, 11A. Incidentally, that is bound to high molecular weight kininogen also. This factor 11A will then downstream activate the common pathway of coagulation. We'll discuss this in great detail later, and eventually result in the production of thrombin. Okay, thrombin will convert fibrinogen to produce clots with fibrin in them. These clots are then degraded by a protein enzyme called plasmin. Now, what is relevant in this is that there is a protein called urokinase which is converted to which is converted from its inactive form, that is pro-urokinase, into its enzymatically active form called urokinase, which then converts plasminogen to plasmin. As you can see, plasmin plasminogen mutations result in increased plasmin production, and plasmin can then activate factor 12, which, as we know, activates high molecular weight kininogen and kallikrein. So, what I'm trying to get at is mutations in factor 12 directly activate this complex, as you can see, and the gain of function mutations in plasmin will result in secondary activation of factor 12, resulting in increased activation of the high molecular weight kininogen kallikrein complex, resulting in angioedema. So these are the two most common non-C1 esterase inhibitor genes that are mutated in patients with hereditary angioedema without C1 esterase inhibitor deficiency. Okay. There are, however, other genes. Okay, so the most common cause is this is by the way also called factor 12. So there are other genes. So one is kallikrein. So kallikrein itself can be overactive, okay, getting activated. There could be mutation with factor 12. There could be a problem with excessive gain of function mutation with plasmin. All of these would then converge upon the activation of this complex and increase production of bradykinin. There is also, however, there are three other genes that can be affected. So what are these other genetic causes? The first one is angiopoietin 1. Second is an enzyme known as heparin sulfate glucosamine 3O sulfotransferase type 6. Okay. And then the third protein is protein called myofurlin. Okay. Now, all of these three proteins, that is angiopoietin 1, again heparin sulfate, glucosamine 6-or sulfotransferase, and myofurlin, result in increased endothelium mediated activation of factor 12. So, increased contact activation. Okay, so essentially, all of these six genetic mutations, and probably more that we'll discover, in the future, result in activation of factor of this rather high molecular weight kininogen kallikrein complex, uh, either de novo or via factor 12 activation. So I hope this much is clear, and that brings us to the end of this discussion. This is actually a very clinically, relevant topic, and this is a clinical scenario in which a lot of mistakes are made over in, diagnosis is done, unnecessary investigations are sent. So a deep and detailed understanding is very relevant here. So this was our first discussion on superficial dermal disorders. Our next discussion on superficial dermal disorders will be regarding granulomatous disorders in the superficial dermis. And I'll, introduce you to Th1 polarizations and the mechanisms within that type of T cell mediated process, and we'll talk about the different types of granulomatous disorders there. And then finally, we'll get into the actual infiltrations of the superficial and deep dermis. And by then, hopefully, my approach to generalized lymphadenopathy and splenomegaly sections would also have reached, would also have covered non-Hodgkin's lymphomas, both mature B and T, and therefore, you'll get a good correlation between the two. So, thank you for watching, and I'll see you next time.